Now we will discuss functional neurological disorder. Welcome to our channel Internal Medicine Made Easy, the online learning platform that provides medical education to healthcare professionals and students to improve their clinical skill and help them in their studies, courses, careers, and research. Functional neurological disorder, or FND, is used to describe neurological symptoms incompatible with an established medical illness. It describes motor and sensory symptoms such as paralysis, tremor, and seizures that are genuinely experienced and related to a functional rather than a structural disease. Many terms have been used to describe FND, like conversion disorder, psychogenic disorder, and in the past, hysteria. Presentations. The most common presentations are functional seizures, also called dissociative or psychogenic non-epileptic seizures, and functional movement disorders, including paralysis. Other common manifestations are somatosensory or visual symptoms and speech disorders. Assessment and diagnosis. A therapeutic assessment for someone with probable FND may include making a thorough list of presenting symptoms, focusing on the mechanism of onset, looking especially for pathophysiological triggers such as migraine, acute pain, panic disorder, episodic dissociation, infection, or drug side effects. It's helpful to ask patients about fatigue, sleep disturbance, pain, and concentration symptoms, which are present in the majority and may determine disability and quality of life more than the neurological symptom. People with FND have often been through negative experiences of healthcare, including being disbelieved. It's often useful to spend time hearing about those experiences, finding out what the patient and those around them think would be most helpful now, and whether they have strong views about the diagnosis. The diagnosis of FND should always rest on clear positive evidence of the diagnosis, typically from a combination of physical signs on examination or the nature of seizures described later. If that isn't present, think again. Dissociative or functional seizures. These are paroxysmal events, often superficially resembling epileptic seizures or syncope. These are common presentations, not only in neurology, but also in emergency and general medicine departments. They are associated with poorer quality of life than those with epileptic seizures. Accurate diagnosis can be challenging and often delayed because symptoms are transient and complete histories may be available only from witnesses. In the clinical setting, dissociative seizures are best recognized using a combination of positive semiological features. Signs that suggest dissociative seizures include a longer duration of more than 90 seconds, fluctuating course, asynchronous movements, side-to-side head or body movement, closed eyes, and memory of the event. Signs that suggest epileptic seizures include postictal confusion and stertorous breathing. Contrary to many people's teaching, a history of urinary incontinence and physical injury are poor distinguishers. Longer duration of events in dissociative seizures places these patients at risk of being mismanaged as status epilepticus. Treating dissociative seizures with anti-epileptic medications can cause iatrogenic harm, delay correct management, and may even exacerbate their events. Improvement with treatment does not differentiate dissociative from epileptic seizures, as 40% of patients with dissociative seizures reported an improvement in their seizures using anti-epileptic medications. Eyewitness reports from both lay and medical witnesses are notoriously unreliable. A recording from a mobile phone may be sufficient, but recording a usual attack Using video EEG may be necessary. Some types of epileptic seizures, for example, frontal lobe seizures, may have a normal ictal EEG, and if the attack didn't occur during the recording, the investigation may be of limited value. Limb weakness and movement disorders. Limb weakness in FND is most commonly unilateral. It has a sudden onset in more than half of cases, which often leads to presentations through stroke services. Patients with functional limb weakness typically report a feeling that the limb doesn't belong to them and sensory disturbance. The whole limb is commonly affected. Diagnosis, however, should be made on the basis of the pattern of weakness and, most importantly, evidence of internal inconsistency between voluntary movements and automatic movements. Functional movement disorders may manifest with any type of abnormal movement. Most clinical studies found that tremor is most common, followed by dystonia, myoclonus, and gait disorders. Less common are Parkinsonism, tic, facial movements like hemifacial spasm, and chorea. Clinical research says that functional tremor should be considered when there is a history of variable frequency tremor, which changes dramatically during externally cued rhythmic movements. For arm tremor, ask the patient to copy a rhythmical movement made between finger and thumb using their better hand. If the tremor in their other hand stops and trains to the same rhythm, or the patient has difficulty copying the movement, then consider functional tremor. For leg tremor, ask the patient to copy foot tapping, and for neck tremor, ask them to follow movements of your hand with their tongue. Functional dystonia typically presents with a fixed abnormal posture rather than other forms of dystonia, which is usually mobile. Functional dystonia usually involves inverted or plantar flexed ankle or flexion of fingers. This presentation of FND is often associated with severe disability, and pain is common. Another common type of functional dystonia affects the face. This presentation, which is especially common in stroke setting, can be recognized by the presence of jaw deviation to one side, usually with contraction of platysma. The lip curls downwards or sometimes upward, giving the appearance of facial weakness. Functional dystonia usually presents with a fixed posture with ankle inversion or flexion of fingers or wrist. In the face, look for jaw deviation, contraction of platysma or orbicularis, and sometimes tongue deviation. Patients with FND complain of problems with memory and concentration alongside their other symptoms. These cognitive symptoms are typically suggestive of attentional deficit, such as lapses in concentration during conversations or reading, walking into rooms and forgetting what one has gone in for, gaps spent on autopilot when going about normal activities, blocks for overlearned information like pins and passwords, mild subjective word finding difficulties, and an unpleasant experience of excessive cognitive effort and inefficiency are also common. Other FND symptoms. There are many other FND symptoms like urinary retention, speech problems such as dysarthria, mutism, or foreign accent syndrome, sensory symptoms including numbness or positive sensory symptoms, especially with motor symptoms, visual loss or diplopia, hearing loss or sensitivity and globus, persistent postural perceptual dizziness describes chronic dizziness as part of a functional disorder. It has specific diagnostic criteria, and clinicians should be wary of diagnosing it too easily in anyone with persistent dizziness.